Good afternoon, everyone. I'm pleased to introduce today's EPH Grand Rounds speaker, Dr. Marianne Cloeron. Dr. Cloeron is an associate professor of medicine at the University of Maryland School of Medicine and an international leader in work disability prevention and occupational medicine education. She is an instructional designer and has developed many online courses. In 2021, she launched a new OEM elective for first and second year medical students here at the School of Medicine. She is a PI for a grant from Maryland's Office for Overdose Response to reduce overdose deaths among construction workers by distributing naloxone from the Maryland Department of Health to engage employers in recovery-friendly approaches to employees with opiate use disorder. Today, Dr. Cloeron's talk is entitled Partnering with Construction Industry to Address Extreme Risks for Opioid-Related Overdose Deaths. Please note this is being recorded, and Dr. Cloeron, you can go ahead and share your screen whenever you'd like.
Great, thank you very much. Appreciate the invitation. Thank you for the nice introduction. Our objectives today, so you can decide at the end whether we've met them. Hopefully you'll be able to name back the three industries at highest risk for opioid-related overdose deaths in Maryland, and I bet you can already guess one of them. Explain at least three reasons why construction workers are at such risk for opioid use disorder and overdose. Connect the risk for overdose with the risk for suicide. Explain a little bit about the organizational challenges. This has been something that's been a real learning curve for me, and I'm finding the industry really fascinating. And then describe what we're trying to do about it here at UMB. All right, so the overall context of this, and I'll be happy to share the slides. This is a link to a website that describes our projects. Dr. Fry is a professor in the School of Social Work. This project is one of several highly interprofessional, interdisciplinary projects. She and I have been teaming up since 2019 on projects addressing kind of the intersection of the workplace and opioid use disorder. And talk a little bit, this project, Operation Prosper, was really geared toward like what's getting in the way of employment for people in recovery. I'll talk mostly today about the Workplace Prosper project in the original grant period, and then follow on. This was another project that we did trying to see whether we could offer online skills training in soft skills for people in recovery. I'm not going to talk about that really today, but just of interest. And then the naloxone for construction project. So Workplace Prosper, one of the things, you may notice the word prosper showing up a lot. I consider it a personal challenge to try to come up with a new acronym that still lets me use the word prosper, to try to get some kind of name recognition, kind of brand. And so Prosper for Operation Prosper was peer reintegration and other services promoting employment and recovery. The Prosper Online had another definition. So it's not usually the same set of words, but we're trying to use the same acronym. So Workplace Prosper is our biggest project and our longest project, and that means partnering to reduce opioid stigma and promote employment and recovery. And we originally had a grant from the Maryland Department of Health with funding from the Centers for Disease Control, Overdose Data to Action, and the National Institute for Occupational Safety and Health. And our original grant period was 2020 to 2022. We had kind of a gap of really over a year. The second grant we got in October 2023, but we really didn't get to start working on it until like January 2024. So we're kind of in the first, just wrapped up the first half of the year for this grant, which is kind of follow on. The basic idea for this is to try to recognize that individuals are part of a larger context, and we've got government, we've got research people like us trying to work on these big wicked problems, but that the workplace, which includes the stakeholders of employers and unions, is part of society and has a role to play potentially that's not in the least bit close to being fulfilled in trying to help people, the individuals, workers, their family members, co-workers that are grappling with various issues related to opioid use disorder. So this is the kind of the big scheme context of our projects. The goals for the first grant period were to perform analysis from some existing databases to try to identify the needs of workers and also employers, in relation to opioids. And we looked at several different data sets. I'll tell you a little bit about them. But also to start developing a toolkit that tries to help employers manage kind of safe work if somebody has to take opioids, preventing overdoses in the workplace, and then policies to try to help people get access to treatment. And then hopefully evaluate the impact and effectiveness. And then, as I told you, it was sort of an interruption, so we'll come back to Workplace Prosper in a bit. Just by way of background, the SAMHSA, Substance Abuse and Mental Health Services Administration, has pointed out that most adults that have an alcohol or illicit drug use disorder are actually employed. And so this represents about 13.6 million workers and about 9% of employed adults. And so we may not always recognize this, but chances are we work with somebody that is struggling in one way or another. It's a very high percentage. In construction, the risks are super high. This is just some of the research that has been published. In Louisiana, there's about 4 times the overdose death rate. In Massachusetts, has the highest rate of opioid-related overdose deaths. Also very high in commercial fishermen, interestingly. And I say men because it is mostly men. In Ohio, about 7 times the risk than any other type of worker. Construction workers are 7 times more likely than other workers. The National Safety Council has estimated that 1 in 5 construction workers has a substance use disorder. And then stepping away from opioid use disorder, the suicide rate of construction workers is about 45 per 100,000 compared to the national average of 14.1. So that's a huge increased risk. So we're going to talk about why. One of the reasons for that we believe, it's such a complex problem, but construction workers are more likely to work in pain. They're more likely to get opioid prescriptions. I'm sorry, why is this? Speaking of why is this automated? And so they're more likely to get opioid prescriptions, and also overdose deaths are just increasing. They've increased 9 times just in that 7-year period that you see on the right. So why is this happening? One problem is that construction workers, it's high exertion kind of work. So there's higher risk of getting an opioid. To wind up with an opioid use disorder, you have to start with an opioid. People don't start out with opioid use disorder. They start out with taking opioids, and then some people wind up with an opioid use disorder. If people are getting inappropriate opioid prescriptions for minor kind of injuries, and we think this is a problem, we're in the midst of analyzing some data that's pointing in that direction, then that's one of the reasons for the increased risk. But people who, and about 15% of workers that have been prescribed opioids for work injuries wind up becoming long-term users. Now that's huge. And a fairly high percentage of long-term users wind up with opioid use disorder, not just chronically on opioids. The other thing that's really important to know about construction workers, and this is true even for those that are in unions, you think of people in unions as having more benefits, more rights, and they do. If you're a construction worker and you don't work, you don't get paid. There's unless you're kind of in management positions, there's little access to paid sick leave. And so they work in pain. And so they may be more likely to use medications to try to help them get through their workday in pain. Many don't have health insurance or the benefits that come along with health insurance. We'll talk more about that as we go on. But there's also a lot of psychosocial job stressors. It's very high demand work. There's very low control of the work. There's so little autonomy, and there's low social support. And there may be also some cultural factors, like how construction workers socialize after work, that may be a contributor as well. So, and it's also male-dominated cultures in general. There's literature that shows that there's decreased likelihood of seeking help when needed in male-dominated industries, including construction. In Maryland, construction workers make up about 8% of the private workforce in Maryland. But they, this is 2018 data, had about 22% of the opioid overdoses. So it's like a higher percentage of what ought to be there. So data from workers' compensation, we are looking at data from the large state fund, which is the one that's most likely to ensure the majority of construction employers, which are mostly small and medium-sized companies. And we did see that opioid prescribing decreased over the years that were represented in the data set, 2008 to 2016. There's a lot of stuff going on then. Those of you who are clinical probably remember, the PDNPs, prescription drug monitoring programs, came into place during that time frame. The FDA started to pay attention and require education on opioid prescribing. So just in general, the milieu was doctors were learning not to willy-nilly prescribe opioids. So that's good. We saw the same trend in the Maryland data set. However, we found that opioid prescription rates were higher for minor injuries where they weren't indicated than for the more severe injuries. And people working in, and this has not been finalized or published yet. We're still working on this. So this is preliminary data, but people working in, as you can see, construction, transportation and material moving, production, manufacturing, all kind of heavy work. Personal cares also includes things like nursing assistant kind of work, taking care of people in their homes. It can be also heavy service and grounds maintenance. So people working in those industries were more likely to receive opioid prescription after adjusting for diagnostic groups. So it's not just that they were more likely to have injuries, but after adjusting for the type of diagnosis, after adjusting for the gender and the year, they were still at higher risk for getting opioid prescriptions. This is another bit of analysis that we did during the first Workplace Prosper project. This just got published this year, but the research question was, do opioid-related overdose deaths, does the death rate, opioid-related overdose death rates differ by industry throughout Maryland? The sample of overdose deaths in the time period we looked at, and this was 2018 data, we are planning to redo this data redo this analysis with current data. But based on the data then, it is majority male, it is majority white, followed by Black. If you were to look at it today, you would see a very high uptick in Hispanic population. At some work sites, maybe 40% of people doing construction work are, not Caucasian or Black Latino or white Latino. Almost 100% of the overdose deaths were in working age. And what we did was coded, well, we didn't do it, but within SUDORs is, I don't know if anybody's familiar with SUDORs, but it's a state unintentional drug overdose reporting system. And so anytime there is an overdose death, it goes into this database. And then there is a kind of a forensic chart review that tries to answer the questions, what did they die from? What were the circumstances of it? What can we learn from this? And and most of the states, if not all of them, are participating in it and then report the information to the Centers for Disease Control. And so if industry or occupation information is included on the death certificates, that goes into it as well. But quite a lot of the time, there is no information about work. If it is documented that the person died at work, that is also that gets into the system as well, but it's not the majority. So this is what was in the data set 2018. Majority of So I'm sorry, when I was talking before about the proportion of the population, I was talking about the construction worker population, not the overdose population. So this population that is that is on this slide is really who was in the Sudor's data set. It was majority male, majority white, followed by Black, and almost 100% working age. When we look, interestingly, it's kind of close to construction work as well. So when we analyze this, what we had to do, so we have the numerator of overdoses. How do we get the denominator of how many people were at risk? So what we used was the current population survey, which is a census instrument to try to estimate the number of workers in each of the occupational groups and industry groups. For those that don't know the difference between occupation and industry, occupation is a person's job, industry is what is the field that they work in. So you may have a security guard as the job that works in a hospital. So that would be the industry would be healthcare, but the job would be security guard. So we looked at the data both ways, both by the job that the person was doing and by the industry that they were working in. So these data are related to the industries, and what we found was construction was at the highest risk, with 212 deaths per 100,000 workers. Manufacturing came next at 99 deaths per 100,000 workers, and transportation and warehousing came next. I don't know if you remember what I said earlier about, go back. Actually, I'm going too far back. This is recorded, so let's not go back. This is just the highest risk. Wait a second. There we go. So people in these industries were also the most likely to receive opioid prescriptions. The exact same three, interestingly: construction, manufacturing, transportation, and material moving. So what are the potential root causes for this? All of these are common in construction. We do have a fair amount of illicit drug use by employees at work, and there are many reasons for that. Also, while not at work, use of prescription opioids that can affect work performance, overdoses at work, and these are increasing. In our work that we're doing with construction, we're kind of shocked to hear how often people are reporting, like knowing about, witnessing, responding to an overdose at work. Sometimes it's people that kind of wander onto a construction site. It's not their own employees, but it's sometimes own employees. Naloxone is not readily available at most workplaces. I mean, would you right now know where to access naloxone where you're working if somebody had an overdose? Workers' comp injuries are often treated with opioids, and they're actually very common in construction. People in recovery are treated differently than people that are recovering from having a surgery or a heart attack. There's not any kind of built-in support for people in recovery in general. The company culture often promotes, going out for drinks after work, partying or whatever. And employees that have substance-related problems are often afraid to ask for help. And then this is an important factor too. Treatment for opioid use disorder is not included in health benefits when health benefits are available. So I'm going to pivot a little bit to some national trends. And is there any way to do audience participation here? Can you give me a sign if you have heard of drug-free workplaces? Can you give me like a thumbs up or something like that? Is there any way to see that? I don't actually see it while sharing. One person, drug-free. You don't have to know the year, but have you heard of drug-free workplace? Feel free to speak up too. I feel like I'm talking to myself. Tracy, raise your hand. Thank you, Tracy. Okay. So in 1988, there was a kind of an act passed, the drug-free workplace, that applied to federal workplaces and federal contractors. And as a result of it, it led to widespread drug testing. So you probably remember in the late 80s and early 90s, there's lots and lots and lots of drug testing in the workplace. And it was also kind of the birth of employee assistance programs to help workers. That kind of gave way to later applications, shall we say, of policies that were zero tolerance. Now, have you heard of zero tolerance policies at work? Anybody have an idea what zero tolerance might mean? This is where doing it live would be more fun in person. Okay, so zero tolerance basically means you get caught, you get fired.
Right.
Or kind of the other side, or maybe sometimes both, not doing drug testing, not addressing it all. And as the competition for workers has increased and unemployment rate has gone down, a lot of companies have, not, they've gotten rid of all drug testing. And the most recent, which I think is a wonderful trend, is recovery-friendly workplaces. Now, has anybody heard of that? Actually, I would love for you to speak up if you can. Take yourself off mute. Anybody have any experience with recovery-friendly workplace programs?
No.
No.
Interesting. Okay. So actually, this was the poll. This started in New Hampshire. The governor basically set up a program to hire contract agencies to work with employers to set up something called recovery-friendly workplaces. I think it's going on about 10 years now. It's kind of caught on. A lot of other states have adopted the New Hampshire approach. In it, basically, if an employer says, yes, I want to join this movement, then they get a whole lot of help to set up policies that will help them be more welcoming to people that are in recovery, make sure their benefits cover people in recovery, make sure their policies are not, like company events are not all centered around alcohol, as an example of a recovery-friendly policy. Also, stigma-reducing education, so people learn how to talk about substance use disorder in a different way, in a non-stigmatizing kind of way. Also, so that people who are in recovery and maybe have a problematic background from the time that they're in recovery are not excluded from the workplace. So it's a very inclusive kind of an approach. A lot of states adopted that approach. And the New Hampshire approach, which is the dominant approach in the country, is kind of an all or nothing approach. It's like you sign up, you get all this help, but you're also expected to do all the parts of it and do annual reports. And I think a lot of the companies that initially joined were things like treatment centers and human services kind of things. It took them a little while to catch on with the kind of more heavy industry kind of firms, but they have a pretty large set of employers that have adopted this approach. The National Institute for Occupational Safety and Health, about 5 years ago, I'd say, published some supports. They called it workplace supported recovery, but it's basically the same thing. It's like, hey, employers, you got to pay attention to this. These are some tools to help you do it. NIEHS, which is the National Institute for Environmental, Health and Safety, I think, got on board, and they've been publishing a lot of toolkit things. And just last year, they published something to kind of look at across the country, what's the landscape for recovery-friendly approaches. Just in the last year, the Department of Labor joined in. They had to call it something different, so they called it Recovery Ready Workplace. But all of them are very similar. And then something just stood up, I think this year, the National Recovery Friendly Workplace Institute. And what do you notice about this, the last graphic I just put up? Anybody recognize that flag in the logo?
You mean the Maryland flag?
The Maryland flag, yes. So Maryland has a pilot program, which we're participating in. Maryland's project is a little bit different than this model. Dr. Fry and I worked as advisors to them, and we are still participating and helping evaluate this. But remember I said that this is kind of all or nothing. You basically sign up and you have to do everything. You got to do naloxone programming. You got to, annually, document that you're training your employees. You got to do your policies. What Maryland decided to do was a more tiered approach, and so employers could adopt part of the program and get a certain designation, and adopt a little bit more of the program and get a different designation. And there are recovery-friendly advisors that are working with employers that want to do it. At this point, it's only being piloted in Western Maryland, in the Susquehanna region, which is Cecil and Harford County, and in St. Mary's County. Tracy, I see you raised your hand. Did you have a question, or was that related to the poll? I'll assume it was the poll.
I also asked her in the chat and she hasn't responded.
Okay, all right, great. So what are the predictors of success in treating substance use disorder? You know, people need to have strong support systems. It has been shown in lots of studies that having beneficial employment, having decent work, is very helpful for treatment success. And in part because work usually comes with benefits. Now, construction work doesn't always come with benefits, but work, you know, one of the benefits is, you know, you get a paycheck, but also access to comprehensive treatment programs. So these three things are predictors of substance use disorder treatment success. What do these have to do with employers? Potentially a lot. We spend a lot of our time at work. And so employment, you know, the workplace can be part of a person's support system, especially if employers are intentional about it. They can make sure that the benefits, that their employees get benefits, and that the benefits include comprehensive treatment programs. All of this sort of fits in with the recovery-friendly approach. The definition of it from the Recovery-Friendly Workplace Institute is a place of work in which the employer, in collaboration with employees, establishes, maintains, continually enhances policies, practices, and a culture and a work environment that are supportive of current and prospective employees that are in recovery from or otherwise affected by substance use disorders. And people that are affected by, you know, would include people that maybe are not in recovery yet, that need treatment perhaps, but also family members of people. So there's a lot of different ways to be affected by substance use disorders, and I think most of us can say that we have been in some way or currently are. The Department of Labor explains that recovery-ready workplaces adopt policies and practices. I'm going to get to the construction stuff shortly. That will expand employment opportunities for people that are in recovery. Will support help seeking. Will make sure that there's access to needed services, including both treatment and recovery support. Will train employees and will inform people that they may have the right to accommodations. You know, where this might come in, for example, is if somebody is on methadone treatment and they might need a different work schedule because they have to go to the methadone clinic early in the morning to get their medication. So maybe a reasonable accommodation would be to adjust their work schedule. Practices that reduce the risks. This is where the training may come in, and educate everybody about stigma to try to facilitate open discussion. And then also just, you know, kind of making a pledge that they're familiar with it and they're recovery ready. So this is a stretch. I mean, I think we have a wonderful employer, and I don't know that I could say that we meet all of these criteria, you know, explicitly, at least. We did do, as part of our project, a survey. We didn't get a huge response. So this, you know, we still have it going. We're still looking for opportunities to expand here. But I want you to notice here that the ones that were people were most likely to have in place were referrals to employee assistance programs and drug testing programs. Paying attention to job protections, maybe a third, you know, intentionally hiring people that may be in recovery, not even 50%, you know, anti-stigma training, you know, maybe a third. Most of these others are about a third. Those, you know, many of them had treatment benefits, maybe 50%. But there's a ways to go, right? So let's talk about naloxone. Have any of you had, I'm gonna stop sharing for a sec so I can see you and so I can see chat stuff. Who here carries naloxone? Anybody carry naloxone? Yay, Roy. Hi, Roy. So, hopefully by the end, you will decide to.
Roy's holding his up.
Yay, yeah, I got mine in my bag. The only time it's a problem is if I'm trying to carry a littler bag. All right, so naloxone is a life-saving antidote to opioid overdose, basically. And this here, this graphic is a foot in the door. We are thinking of naloxone as a foot in the door with the industries that we're talking with, because they may not be ready to put policies in place that give people a second chance if they stumble and are caught, using drugs, go to treatment. They may not be ready to give people their job back. But I think a lot of companies, more and more companies, are ready to try to save a life. So it's an easier bar to reach. And so we're thinking of it as a foot in the door to start having relationships with businesses to start talking about these things. So we got a grant last year. It's over now. It was just a 1-year grant it was originally, the grant was from the Maryland Opioid Operational Command Center. During the time period of the grant, the name of that organization changed to Maryland's Office of Overdose Response. It went from kind of a freestanding governor's office to under the Department of Health. But our grant the objectives were to try to engage the construction industry. And we know they have all these overdoses. And we know that most of the overdoses are not happening in the workplace. So we want to get naloxone into the hands of construction workers so that they may be in a position to save a life, no matter where they are, whether it's at work or, after work. And so we were going to try to use an academic detailing approach, basically knock on the doors and persuade them. We were going to try to connect them with, you keep on hearing my past tense here. It's not just that the project's over, but the plan was to connect the construction employers with naloxone training in the community. They're all over the state. There are overdose response programs that do naloxone training and distribute naloxone, and we've got maps of them. And so, thought it'd be very easy to just, contact the construction employers and, let them know about the problem and hook them up, get the training done. So those were the goals, and then to try to document the barriers and facilitators to uptake. We did have an advisory board that included the Maryland Center for Construction Education and Innovation, CPWR, Center for Construction Research and Training. Those of you who are very observant may notice that these letters don't equal this acronym. And that's because they kept their old acronym. It used to be the Center for Protecting Workers' Rights, which tells you that it's kind of a labor advocacy organization. NAB2, which is kind of an umbrella group for the building trades unions. AGC, so AGC and ABC are the trade associations, basically, of contractors. You can see there are others. So again, these were our goals. And this was our approach. Cold calls from a database. We also made presentations at construction safety events, and our plan was to connect them, for training. So what worked and what didn't? What do you think? Amber, you are not allowed to say. Amber's somebody in my group. And Jaden, you're not allowed to say. I've got members of my team here. How well do cold calls work in your experience?
Not always well.
No, that didn't work well at all. I think we kind of knew better, but we were kind of hoping, we actually, when we first wrote the grant, we were hoping to get a peer specialist with a construction background. We were hoping to use an industry insider, and that was like impossible. We couldn't find like the right person. So we had a lot of staffing kind of problems. So the cold calling part didn't work. The presentations at conferences actually was very successful. And let me share what happened. Oh, and so what do you think what about the idea of connecting with the community overdose response programs? How well do you think that worked? Any of you ever passed a construction site?
I have I'm Georgia.
Yeah, hi, Georgia.
Yeah, hi. I would possibly think that it would definitely help as far as, collaborating in a community because you find other people that have experienced the same thing as you. So it makes it easier for that person to communicate with that person at that level because sometimes people are very insecure and afraid to really express how they feel at the time. So it's like having the people that go through it together, so it makes them feel better about each other and helps each other as well.
Now, I think you're
Yeah.
absolutely right, and that's kind of what we thought. We had to go through the employer to kind of make it happen. So the logistics of trying to get the kind of community-based overdose response programs to be able to figure out how to meet the needs of the construction sites or the construction businesses was kind of a bridge too far. So we gave back all the money and said, forget this. No, we did not do that. But we did, nobody does that, right? We did find our champions, and they were the construction safety professionals. They knew that there were problems. They see the problems, they respond to the problems. They're the ones that teach their workers CPR and automatic defibrillator training and first aid training. And they like they grabbed this and kind of ran with it and helped us do a pivot. And so the pivot was that we became a workplace facing overdose response program. And we have been since January, we sort of piloted this part of it in January, halfway through our grant year, training construction safety professionals to get out there and do the training under our authority and get the naloxone out. So we're getting naloxone from the Center for Harm Reduction, and we're giving it to the construction safety professionals who are training their workers and getting the reports back to us so we can report on it. And members of my team are here, so say hi to Jaden and to Amber. Jaden is our primary trainer, so she's going out and doing this training. And even though our contract ended with more, we are able to continue this work under our current Workplace Prosper grant with MDH. And we're also looking for grants to be able to expand it. So this is an example of something that we have used at construction safety events to try to get their attention. And it was actually a very, in the beginning, we were kind of paying for our spot at these conferences. We were registering as exhibitors. And now, people are contacting us. Can you come and present? Can you come and do a training? Can you come and get naloxone out? So it's been really very remarkable working with the construction safety people. You may have seen in the Elm my pitch for or my plea for people to come and help us assemble these kits. We get this from the Center for Harm Reduction, the naloxone itself, but if people are going to do rescue breathing, they need to have a face shield. So we have purchased face shields. We put in it instructions double-sided in English and in Spanish. We have a Spanish construction safety trainer who's working with us. We include gloves. We also have people like helmet stickers. So we made helmet stickers, and we have this great little bag to put it in. Here's a picture from one of the trainings. This one, you can see this is actually Jose, our trainer, our Spanish-speaking trainer. Jaden, again, does most of the training. So let me ask you now, what do you all think a construction worker does? Explain to me, what does a construction worker do? It's a little bit of a trick question. Come on, speak up. This is supposed to be interactive.
They can they have many different levels of jobs that they have to pertain to because it all depends. Like some construction workers, as a matter of fact, this morning I was on the light rail. This construction worker was moaning and groaning that he had to meet some guy because he had to drive the truck. So it's not all,
Yeah. So it's not just,
it's not all about just being on the road and doing all the the yard work, the heavy work, or the other work that it involves, but it also has administrative. Sometimes they want them to go in the office. So it's funny that you mentioned that because on the light rail today, this guy went out, shut up. He was like, I really don't want to drive the truck. He preferred to be outside. It's interesting because he preferred to be out in the heat because I guess that's what he knows how to do, and he enjoys that rather than being in the truck.
interesting. Yeah, okay. So sometimes when I ask this question, like when people come to volunteer to put the kits together, I'll ask, what's a construction worker do? Because they ask, why this project? And people often will say something like, heavy lifting. Well, probably, but let's go into more detail. The other question I want you to think about is, who does a construction worker work for? And this is a trick question. These are both trick questions. So just on kind of a very gross level, at a construction site, you're going to find people that, to start with, there's site preparation that might involve demolition, and you will have companies that are demolition experts. They'll come in and they'll do the demolition and cart off the stuff that came down. If any of you go past what the old Perkins Home site that's going up, I walk past it when I come to work pretty regularly, and it's a really great example of kind of the phases of construction. So in the early phases, you're getting the site ready. It may include excavation if you're going to have cellars, paving, laying a foundation. And then you have the building, which includes, putting in the steel beams, putting in the elevator in the middle, doing the carpentry, the framing, all that kind of stuff, and eventually the roof and the windows. And then you've got people who specialize on electrical work, plumbers, HVAC. Each of these jobs, there are skilled trades with apprentice schools that teach people like these specific things. And then you also have laborers that that will assist them, but are maybe not licensed to be specialists in any one of these things. And then the finishing, so the people that put in the floors and that paint the walls and maybe do the driveways and the landscaping. And in our project, we've worked with contractors that have this, like we're a fencing contractor or we're an HVAC contractor. And so there are many, many different jobs that can be represented by the term construction worker. Some important organizations are NABTU, which is the umbrella organization for the different building trade unions, but also ABC, which is the one that there are some other trade associations, but we've worked most closely with ABC, which is the merit shop group, which is the companies that don't work with unions. They don't hire unions. And there's some political and cultural differences between the different types of work settings. CPWR, I mentioned before, the Center for Construction Research and Training, wonderful organization. We do a lot of work with them. They've developed a lot of useful materials, but most of them are really designed, and most of the research that they've done is related to the union environment. And it may not be easily applicable to the merit shop environment because there are some differences. So I want you to get ready for, okay, everybody hold on to your seats because the next graphic is complicated. But I think it's a really important graphic. All right, scary, huh? All right, so you have a construction project that needs to be done. Usually what happens is a general contractor will bid on it. That things like, Whiting Turner, Davis, there's the Clark Construction, you've probably seen signs for them. These general contracting companies typically they have a safety team as part of their management team. And then they'll have managers for the different sites. And so a general contractor may have, 5, 10, 20, 100 different sites. There are small general contractors too, which may have just 1 or 2 sites. But at a site, depending on the phase of construction, you may have excavation going on in one part, and maybe that's, that has already been done and the carpenters are busy on the next part. Then you have another contractor. And at the other site, they may be on to paving and roofing, et cetera. And each of these trade contractors is its own company that specializes in this trade. Sometimes it's 2 or 3 different ones. And so and then they may have their own employees. They usually do have their own employees, but they may also need to hire some temporary work. And so these may be temporary hires, but they may also be so-called self-employed subcontractors that basically they don't have any autonomy. They don't have any of the benefits, but they're self-employed subcontractors. They file 1099s. That's these actually. So the temporary workers are hired through agencies and then the subcontractors. So this whole group in the dotted lines here don't actually belong to these guys. None of these guys belong to the general contractors that have the big resources. Some of the contracting companies have safety specialists, but a lot of them don't. And then you've got the subset, depending on who you talk to, 10%, maybe 20%, that are union construction workers. So the people are hired through labor unions and they get their benefits through the labor unions. So how's that for complicated, right? So who is responsible for making sure that these guys get training, have benefits, get support, have naloxone? Are these guys going to pay for naloxone kits for the thousands of workers that may pass through their sites in a month? You know, and maybe, there for just a few weeks. So you can see some of the challenges in getting this done. And it was one of the reasons that these guys, the safety team, the safety specialists at both the general contractor level, at this level, and also the unions, were all very excited to hear that we were able to get the naloxone itself through the state. And and they're actually helping us do the training. So they are committing to getting the training done at the work sites. So it's pretty remarkable. So if you think about a common scenario, somebody gets hurt on the job, chances are in Maryland, it's not going to be a union employee. Chances are it's not going to be an employee of a general contractor, maybe an employee of a trade contractor, but it may also be about 20% are these self-employed self-contractors. What does this mean about workers' comp or health insurance? And none of them really get sick days. Even the people that are union construction workers don't get any paid time off. But the self-employed independent contractor, I can tell you my stepson is one, not in this state. He doesn't carry workers' comp, and he can't afford health insurance. And this is a lot of them. So how are you going to take care of yourself if you have a work injury or if you have pain? So I think it can explain, some of the problems that we see with opioids. So I think this is a good example of a wicked problem. It's, challenging to figure out how to fix it. It's systemic. There are high level, there's a large part of it is kind of a system problem. There's no clear cut universal solution. And it's going to go on. What about suicides? Suicides are a lot higher, and they go along with overdoses. I consider it a syndemic, overdoses and suicide. So CPWR did have a workshop on this. I'm going to share I'll share a little bit from a white paper that came out of this. I went to this. This was in 2022. It was very interesting. It was a lot of trade unions, but it was also merit shop employers. Some of the big general contractors were there, and also the trade associations that don't work with unions were there. So it was very representative of the construction industry in general. All comers. And so they asked some of the similar questions. So who is going to develop or provide these policies, the programs, and the training? For the guy that I was just showing you, the 20% that are so-called independent contractors, who's going to conduct research related to mental health? And who's going to be included in that research? So you can read through these yourself, but these are really challenging questions. And we're trying to address it. So, thinking about who's got the responsibility for setting up a peer support program and who would it be for? A lot of the trade unions are setting up peer support programs for their union members. That is not universally available. That's not available, as far as I know, for any of the merit shop kind of employers. And so how do we get people peer support? I think you all know that peer support is, when we're talking about, there's both mental health peer coaches, and then there's also substance use, peer recovery coaches. And in Maryland, there's licensure, I believe, for both of them. I know there is for peer recovery coaches. But that may not be available to anybody other than the people the minority that are hired through unions here. And it has a lot of implications for programming with the whole recovery-friendly approach. How in the world do you put something like that in place with that labyrinthine organizational structure? So our current projects, we are through our project with Maryland Department of Health. We're continuing the Train the Trainer. It's going strong, and it's very exciting. We are helping the Maryland Department of Labor evaluate its pilot program on recovery-friendly workplace approaches while trying to promote the program and recovery-friendly approaches with the Department of Health. And it's really been a very nice collaboration between the Department of Health and Department of Labor, and it's a lot of fun to work on that. We also have a small grant through CARES, which is in the School of Social Work, to try to combine suicide prevention training with naloxone training for construction. That's just getting started. We're working on a literature review that grew out of that workshop I told you about in 2022. So we're working on like what works in construction, and we have several grant proposals that are cooking to try to study peer interventions and workplace programming. I did include some of the citations of things that we've published related to this, and I can stop here for questions or comments. I went very fast. There's a lot to cover.
Hi, Marianne. I have a question. First of all, thank you so much for a really great presentation, and for all the great work you're doing. It's really wonderful to hear about. I was just curious, given what we know about sort of higher rates of stress and burnout in healthcare workers, I was sort of surprised to not see the healthcare workforce in your list of top industries, I guess. And so I was just wondering if you could comment about that, if you have any idea of why.
Yeah, they have not come out as high opioid use disorder deaths, which is what that study looked at. And it's not a population that I do deep dives in, so no, I can't really address why we're not seeing them in overdose deaths. Yeah, it's interesting.
Okay. Thanks.
Actually, burnout though is a big problem in construction as well. Wendy, did you have a question?
Yeah, so I was going to ask about naloxone, and I was thinking about having it in my car. Are there temperature?
That's a good question. That comes up a lot with the construction workforce, as you might expect. It is, so naloxone when it's produced is supposed to last 3 years. So it's supposed to have a shelf life of 3 years. It does have some degradation in high heat. There have been some studies looking at the drug itself, and I'm trying to remember the details of it, but basically they put it in an oven, and then they froze it, and they put it in an oven, and they froze it, and they put it in an oven, and they froze it, and then I think about a month of that to see if it still worked in animals, and it did. So that kind of like temperature extreme abuse, didn't ruin its effectiveness. What we tell the construction workers is you want it near you. And if you have to replace it because you think it has been in the heat too long, then we'll help you replace it. We're just guessing that maybe a year in the heat, may be enough, but it's not going to harm anybody if it has, it may not help if it is degraded. One of them asked a really interesting question, like if I keep it in the heat, can it burn somebody's nose? I thought, maybe, like if you're keeping that in your metal toolbox, it may, and so our answer was basically, if it's too hot to handle, it's too hot to put in somebody's nose. So wait until you can, wait until it's comfortable for you to handle it and then use it. But we generally recommend, like if you can keep it someplace cooler, then keep it someplace cooler. Maybe keep it in your cooler at work, where you keep your lunch. And then keep it in your garage, in your car, in your garage, otherwise, type of thing. But keeping it on hand in a hot place is better than not having it on hand.
So that's how it's administered, it's inhaled?
Yeah. And we have, we're doing naloxone training here. I actually do have an online naloxone training that we offer to the students. If anybody wants to just take the training, it also includes where you can get naloxone. I'd be happy to share the link to that online training, because the construction workers that we work with, we give them a whole bunch of training materials, including this video that they can use if they don't want to do the PowerPoint.
Yes, if you could share that link in the chat, that would be great for everyone. If you have it handy, if not, I can send it out.
Actually, while I'm answering questions, Jaden, would you mind finding the link for the training and putting it in the chat for us?
The link for the training video?
The training video in English, yeah, thank you.
Yep.
We have it in Spanish as well.
I have a question. How is naproxen given? Is it by mouth? How is it given?
Naloxone, well, there are 3 different ways that you can give it. The way
Okay.
that the lay people are most likely to use it is
Okay.
nasal. It's a nasal spray.
Okay,
In the hospital, it may be given by vein. In ambulances, it may be given by injection, but
oh,
um,
okay,
it's a nose spray.
no spray.
Yep, single dose. So, and in the boxes, you get 2 doses. I don't want to go through the whole training here, but everybody
Thank you.
gets 2 doses
Fun.
for the training. You're welcome. Thank you, Jaden. I hope I get a chuckle for the name of the website where we keep our training. Docs Rock.
Yeah.
Roy, did you have a question?
Yeah, if you would you consider other partners, other groups partnering? Because I'm president of the Maryland chapter of the American Physical Therapy Association now, and
Sure.
we've been talking about doing something like this, and actually have started a couple of years ago, started working with a group, and haven't been doing a heck of a lot with it. And we could probably easily mobilize some folks to help out.
Yeah, I think let's talk.
Yeah.
We are partnering with the different construction safety groups and the safety training groups like the Chesapeake Region Safety Council. We're going to start tagging on our naloxone train the trainer with where they're training construction safety people in something. And we're trying to make it convenient for the construction safety people. I mean, you guys might have some questions of Jaden. She's one that interacts most commonly with the construction workers. I don't know, Jaden, if you're open to answering any questions about what it's like kind of interacting with the construction professional community.
Sure, I can answer any questions if anyone has any about the training or interactions or anything like that.
What kind of questions do you get from, oh, Alex had a question. Alex, do you have a question?
I do. Sorry. I was just trying to like press buttons here and there we go. Thanks for that presentation. I'm sorry I joined late. So if I ask you a question that you've already discussed, just you can give me a solid eye roll.
Okay.
But I'm making this I'm making this parallel for my own research right now, which is somewhat vastly, well, it's very different for the most part. So I'm in diabetes and I look at hypoglycemia, and there's actually a nasal injection called, it's a glucagon agent, but we have a nasal spray now, and it could be used by anybody. So I'm thinking about, okay, there's a parallel here between naloxone. It's also a life-saving agent, in some ways could be described as an antidote for somebody who's having severe hypo. You can just go and give them this nasal spray of glucagon and the person could be revived. And so my question is, and I know that these are in entirely different contexts, but what types of barriers have you encountered, not necessarily around training of it, because perhaps the tool itself is quite easy to use, but around like the availability of naloxone, getting it into the hands of the public? How do you get like different organizations to say, yeah, our people should have this on hand? I mean, glucagon isn't even given to people with diabetes on a regular basis, nor is it something that even teachers have. And then how do you balance that also with a prevalent story, where you might have payers or whoever providing these services be like, well, this isn't really that big of a problem to like give everybody naloxone. So how have you guys managed that? Because I'm thinking I would love for everybody to also be carrying around glucagon too.
Yeah. Well, luckily we had the prevalence part covered. It's the highest rate and everybody knows it. And, they're all reporting, so that wasn't a challenge. I think for us, it was really the game changer for us was being able to supply the Narcan part free. And, we have the grant paying for the kits. So they have to invest the sweat, the time to go to the websites, the work sites to go and, provide the training to workers, but they were willing to do that. I think you would have to find, I think, evidence that there's enough of a population need, but, a lot of the construction safety professionals are paramedics, and so that might be, your audience. I mean, do firehouses carry it? EMTs? No?
Yeah, I do know EMTs carry it because I have some friends who are EMTs.
No, I mean the glucagon.
The glucagon,
Oh, I
yeah,
don't-
not the
sorry.
nasal version. They
Yeah.
kind of have the more traditional version of it.
Yeah,
But
that's
it's-
challenging. Roy, did you have another?
Yeah, I have a question for Jaden then.
Oh, okay.
Oh yeah, there she is. Her box moved. So my question is about the stigma that the workers might feel, and how much resistance do you encounter? Do you feel like a lot of people are unwilling to disclose? And if it's physician prescribed opioids, that's one thing. Probably a lot less stigma, but with rates of fentanyl use skyrocketing, I wonder like how much do you feel you're able to get through to construction workers?
I feel like I've had a really positive experience with getting through to construction workers. I always take on every training as, even if the person isn't open-minded, this is my opportunity to change that. Because the facts are the facts. I'm a logical leading person. So I found that although people might not be super comfortable to maybe disclose every single detail about their experience that led them to be in this room, what's important is that they made it in the room and you got your foot in the door. And I'm a firm believer that if they sit through our train-the-trainer program and our training program, that they will see the importance of the program by the end of that PowerPoint. And even just in having open discussions, like you have some organizations that are a little bit more strict and a little bit more zero tolerance, for example, that still want to have these in the workplace, but are very weary of having it because they don't want this idea of enabling drug use. However, the biggest opposition to that, I would say, is that if people are using opioids in your workplace, they are going to use them regardless of you having this life-saving training or not. What it comes down to is, do you want to save your workers? These are your peers. This is your community. And even if it's not someone in your workplace, you probably know other construction workers that are friends, partnerships and things like that. And at the end of the day, even if you're not training your workers because you want them to use it for themselves, train them so that they could save other people. So it's all about perspective. And when you change your perspective, things get a whole lot brighter. So you kind of just gotta assess who you're talking to at the moment and alter your approach. Some people are really excited about the program and don't need any convincing. Other people, you have to kind of hit it from all different angles. And we're in Baltimore City, opioid use in the city, and we may have a different understanding of the opioid crisis than somebody who maybe lives in the county, or maybe someone who we work with people that are a part of construction staffs that are more on the administrative side, than more so working with construction workers. So you just have to really know your audience at that point and navigate it from there, but just really never give up and just be persistent and be kind, because someone being resistant to it doesn't mean that they're ignorant or that they don't want to learn. It's just, you never know what that person's been through to make their, outlook negative about opioid use or even Narcan. So just keeping an open mind and continuing to be persistent and getting your foot in the door.
Thanks, Jaden.
I was just going to say thank you both very much. It was very informative. I had asked Jaden to place her email in the chat if anybody has further questions for either of you.
Cool.
I will
Thank
put
you.
that in there now.
Thanks
Thank
for the
you.
opportunity. I'll send the slides along.
Yep,
Thank
thank
you.
you.
Thank
Appreciate
you.
all the knowledge you all have.
Thanks. Bye-bye.
Thank you very much. Bye.